I've got a few minutes to talk with you, and rather than try to sum up, which I think is an interesting range of views, what I wanted to ask was the first foray here into the broader discussion about what would it look like, or how would things be different if for instance, Justice Emmett Hall's vision of a Pharmacare system for all was to be realized. So Marc-André mentioned this, that in 1964, the Hall Commission did recommend that we move towards a universal system of prescription drug financing with a $1 copayment, I think at the time, which if you projected forward would probably be on the order of $10 to $15 today. But if you had a system which was universal and publicly financed, how might things be different? And if you could each maybe reflect for a minute on that, I'd appreciate it. And we'll do it in order if you don't mind. So Marc-André, to put you on the spot with that one.
Well, what would be different? I think first thing, it would be a better access to medicines for people who need it. It's just some people do not, in Canada, it's 10% in terms of people not able to fill a prescription because of financial reasons, but prescription for essential medicines. So I think in terms of coverage, it would be way better. In terms of containing costs, the thing is, we see usually, okay, universal pharmacare would be, we accept to reimburse every drug. No, we accept to give ourselves the institutional capacity to do strong health technology assessment of new drugs in order to make sure that we get some bang for the buck. It's just, I mean, nobody would accept to pay $60 for a coffee at Tim Hortons, but when it comes to prescription drugs, it's just, oh, newer is better, so yes, we accept to pay this type of money for stuff that we sometimes just don't need. So in terms of building this institutional capacity, I think that would be a main difference. And also just build on basic Canadian solidarity. It's just right now what we see, for example, with all these confidential agreements, these product listing agreements, is just, okay, I can manage to cut a bit of a confidential deal, so I got my little rebate here, but at the same time, the rebate, this is in order for me to balance my budget. This is not something I give back to patients. This is not something that will be that private plans will benefit from. If you pay out of pocket, basically you pay the full price. And what we do basically is that we try to balance our own budget by shoveling the costs on others. It's just, if I can get a good deal, basically it's by, sorry, screwing others.
So, and Barbara, if we could turn to you, and actually Marc-André...
I missed that last part.
Notwithstanding that last part. Marc-André mentioned this challenge of, we know that negotiated reimbursements, rebates occur between insurers and drug plans, and we know that your team of staff with the ministry are challenged with managing this complicated file. How might those management practices differ if you were actually covering medicines for all residents of the province?
Well, I think the whole system would be hugely different. I think that we spend, if you look at Pharmacare, if you look at the Pharmaceutical Services division in British Columbia, and I was saying this the other day, that we are less than 100 people, basically, for a $1.1 billion organization. And we spend an inordinate amount of time, and Kelly and some of his staff are here, actually negotiating, right? Driving those prices down, negotiating. And I know that a number of you from industry are phoning, and you're usually unhappy, talking about the prices and the caps and again, that complexity. We spend so many resources, so much time, trying to, in all honesty, trying to make the system work, trying to deal with what we have in a province of 4.5 million people, and we don't actually have the time or the energy left to look out, to look across, to look up and say, what is it that we should be doing? What is it that we have to do in order to make this? And I don't think it's a dream. I think it is a reality. Happen. Like, how is it that we are going to find the time and energy to do that when we are so focused on just kind of keeping the boat afloat?
And Colleen, from the perspective of unions and workers, what do you think it would be in it for them, so to speak, if that vision of national pharmacare you described was to come to fruition?
Well, the first thing that would happen is that drugs would be off the bargaining table, which would be a great thing, actually, because there's so much contention around this issue right now. Also, I think that unions do have an orientation towards a more equitable model. I mean, unions were on the front lines of fighting for Medicare generally, along with other groups, particularly farmers and so forth. So I think that it meets a kind of an equity goal within the labor movement. But I also think that if we don't make some changes, that there are going, I mean, people will go to the picket line to defend their drug benefits, and in the health benefit package, drugs are a majority of the cost, and people will go to the picket line to defend that, and employers also are very, very stressed. The other thing I do believe is that while the benefits are a part of the payroll package, and unions are making sacrifices on the wage front in order to basically protect some of those benefits. And I think that within generally the payroll package that there needs to be a redistribution. I don't know how else to describe it, so that there's not, so that the money that is going to support drug and health benefits should be transferred to other areas, either in the form of wages, gym passes, whatever. I think that that these things are on some of the bargaining tables, but they're not there. That's only in a minority of cases. With a national Pharmacare program, I think that a lot of the pressure in that arena would be alleviated.
Thank you. So, Marc-André, I've got a question for you, because your $10.8 billion figure is a provocative one, and you are a proud Quebecer, and Quebec is home to, I believe it is 42% of the pharmaceutical industry's research and development expenditures. We know, for instance, just this past week, a major manufacturer of medicines in Canada has threatened to remove or eliminate, withdraw its R&D investments in Canada owing to patent legislation underway right now. How viable or how real do you feel the threats are that if we were to make a major reform, is it political suicide for a province or for a federal government to say we're going to make a big reform that might actually jeopardize those R&D dollars?
Well, in terms of the R&D dollars, first, for me, I just want to say Quebec Pharmacare right now, it's absolutely not a model that we should follow in the rest of Canada. This is the model where this is still a hybrid system, and this is still a system organized, in fact, first and for part of the politique du médicament in Quebec. One of the points is we need to organize a policy about access to medicines in order to make sure that we provide good incentives to attract R&D investment in the pharmaceutical sector. So it's part of the policy that we need to increase the revenues of the drug companies in order to attract investment in Quebec. It's just, well, I'm sorry, increasing revenues of the companies, it also means directly increasing the cost that we're paying as well. In terms of political suicide, it's just, for sure, as soon as you reduce the markups and revenues for drug companies, they will be not very happy about that. Now the thing is, there was a recent report, University of Minnesota, about the flu vaccines that said something amazing, saying, the problem right now is that as long as we accept to pay any price for any vaccines, any flu vaccines, basically, we provide absolutely no incentives for drug companies to improve the flu vaccines, and we accept to pay a lot of dollars for crap, basically. And as long as we accept to pay this type of money without demanding real therapeutic advance, basically, we won't get that therapeutic advance. What I strongly believe is that you don't need to be nice with drug companies. You just need to be clear in terms of what you want. And if you impose your condition and you explain rationally what are your conditions, basically, they will not like you, but they will respect you.
Thank you. So, Barbara, I'd like to end this session, at least my questions for this panel, on an upbeat note. And that note, I think, in recent years, has been a spirit of cooperation amongst the provinces in recent years on this file. We've heard of the trials of the National Pharmaceutical Strategy that was off to at least what you might describe as a bumpy start. But at least at the provincial table, there seems to be a level of cooperation, most recently with the announcement on cooperation around the 6 high-volume generics. Can you talk to us a little bit about that and about whether you see that carrying forward over the next few years?
Well, thank you. Yes, there is. I mean, the Council of Federation meets on a regular basis, and as has been pointed out, the drug costs, the healthcare agenda is top of mind I would say, for all premiers. So that it is kind of ripe. The ground is fertile, I think, for us to take those opportunities. I think Alberta and Saskatchewan are leading that generic process, and I think they were pretty clear in saying that those top 6 moving to 18% April 1st is the beginning, right? It's not a one-time kind of announceable that we sometimes see. Coming out of those meetings, that there is a huge level, I think, of commitment, but we do need to work together. So I think, as I pointed out, it's not just about driving the cost down, and looking only at one sector. We are trying to certainly, as a country, get our heads around what that bigger picture looks like and what steps that we can take, excuse me, that are palatable both politically and financially. So it's pretty exciting, actually.
Thank you.